The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell again from Leading Age Michigan, and we want to welcome you to our 24th Safe and Calm member webinar over a full 4 months. It's kind of amazing how time is flying by, and yet we continue to be facing a pandemic that has no clear end in sight. So today, we're going to start with advocacy, as usual, and Dalton has a few brief updates for us, and then we will do the routine situation summary. But then before we get to the resources and guidance section, we'll take a few minutes to review the themes from our member polling that we did on Friday and give you one more chance to comment before we use these to support our advocacy plan updates. With the governor's task force on nursing home planning for the second wave, probably convening before the end of the week, this will be one more tool that Dave can take with him to inform that work. So with that, we will turn the presentation over to Dalton.
Good morning, everyone. For today's updates, you're going to see a general theme. This is largely due to the legislature being back in town this week for, they had 2 days of session, today and tomorrow. So a lot of this is being updated and changed right now, and it will probably, the session today will probably go into the night, and they'll be getting things done. There's ongoing negotiations for a lot of this, and so we'll see some general trends here. Right now, it's really issued by the legislature and the governor are playing nice on some things and not playing nice on others. Thankfully, the budget is one they're playing nice on, so we won't have another budget crisis like we did last fiscal year. So with that, the first thing I want to provide an update on is Senate Bill 956, which is the LUCIDO bill. This is the bill that would establish those direct care facilities for COVID positive patients, one in each of the 8 HSAs, and also require the department to review each individual regional hub for their quality and effectiveness and review that program as a whole. Yesterday, the bill was passed out of the Health Policy Committee, and it is now in the Ways and Means Committee. I see there's a typo there, and it's not no, it's now in the Ways and Means Committee. And the legislature wants to put this on the governor's desk by the end of the week, and that is their plan right now. They plan to pass that out of Ways and Means today, and then move it to the House floor, and then move that to the governor's desk where she is expected to veto it, as she's not happy with it because it counteracts a lot of the work she's done, and they're staying pretty quiet on the regional hub program. A substitute was adopted before it was changed, or before it was passed out of health policy. So there's a couple of new things to the bill. Newly added, a SNF cannot care for an individual with COVID unless that SNF has a separate COVID-specific building. Before, a SNF would be allowed to care for patients who were COVID positive if they could demonstrate that their dedicated unit was effective and safe for the consumer and that it passed a LARA inspection. Now a provider has to have an entirely separate COVID dedicated building to care for COVID positive individuals. Also, a hospital must transfer COVID positive individuals to the dedicated facilities unless the individual is a resident of a SNF that meets the above criteria. So hospitals will have to transfer all COVID positive patients to these direct care hubs unless a SNF can prove that they meet all the criteria to care for them. And it also specifically says that individuals are not eligible to be admitted to AFCs, but it also instructs the department to come up with a plan for how all these transfers will work. Next, Senate Bill 899, which is the legal immunity bill, is back up on the table. It was just in committee this morning at 8:30, where it was passed out of that committee to the House floor with a substitute that removed the criminal liability out of the bill and also specified that the immunity would be only for COVID-related actions for the providers who are covered in the bill. We do know that the legislature and the administration are trying to get something done in regards to legal immunity, but we have heard that negotiations are not going well. So right now, if they were to put it on our desk today, she would likely veto this bill. But we will see. The negotiations are still ongoing. We heard last night didn't go very well between the two. We do know that trial lawyer groups are very active with the administration and strongly opposed to the bill. We have offered support for the bill. We provided testimony when it was first up 2 weeks ago. I provided some this morning in form of writing. And we asked that the bill specifically include AFCs and CCRCs to the list of covered entities because it doesn't specifically call them out and leaves some wiggle room for interpretation for the court to decide. We'll see what happens there, but largely this is going to be just moved to her desk as is and face a veto pen. That's where we stand now. Budget update. I want to say within the last half hour, they released details for the FY 2020 budget. As you know, they had a $2.2 billion shortfall in FY 22, and they're using some of those COVID funds to backfill that budget shortfall. We did see some additional spending cuts 30 minutes ago, but none of them, as far as we can tell right now, we've had like 15 minutes to review it, affects long-term care providers. We'll be going over that in some more detail in the coming week and tomorrow for Friday's call. As I noted here, details will be released today. The budget shortfall was filled by CARES Act dollars and other transfer and funding shifts. And by doing this, they largely kick the actual hard decisions down the road to FY 2021, which will make that budget really strenuous, really hard for everyone involved. And there have been bipartisan calls for federal assistance for FY 2021. The next two slides are some of the past charts you may have seen in some of our calls. They show where the COVID fund dollars, the CARES Act dollars, are going to backfill the budget in the FY 2020 budget. So there's this slide and the next slide, which show the funding amounts. We won't go over them in detail because we already have, but these are just kind of fun charts so you can see where the money's coming from and what it's being allocated to. So an update on the PPE grant process that comes out of Senate Bill 690, which is kind of the other half to Michigan's CARES Act funds pot. MDHHS is still working on grant applications, and they're kind of stuck where we kind of thought they would be, because we had a lot of questions going into it about how they define the provider groups for the bill. So MDHHS has gone back to the legislature to ask, what is a residential congregate care facility? What was the intent behind this? So they're looking for a little more guidance. I think this is a good sign because it shows that some progress is actually being made, and we have heard that they are working on this. Just an update for those who haven't heard, the direct care worker reimbursement process is out for that $2 in hazard pay increase. And later on in the presentation, Deanna will be doing a more detailed review because she's been getting some questions and been compiling the answers to those for everyone for this call. So what a nursing home has to do is use the direct care wage pass-through reimbursement form that is attached to today's webinar handout section, and then submit that form on a monthly basis to MD, that email right there. I'm not going to read the whole thing. Important things to note, nursing homes are required to track eligible expenses and retain documentation, and these documents must show that the payments were made to staff and made to only eligible staff. Another thing is that payment will be determined by comparing wage levels effective July 1st to wage levels in effect June 30th. So an easier way to say this is that wages in July, for July 1st through September 30th will need to be $2 an hour over the wages that were in effect on June 30th. And then MDHHS will be issuing an L letter later on to offer further clarification. We've also attached the most recent FAQ that MDHHS released yesterday to the handout section for your convenience.
All right, thank you for that, Dalton. Before we can get to the questions, Leading Age Michigan would just like to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the list of names here up on the screen. These are the organizations that continue to support the association, but your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. So first question, can you clarify that if a facility has a COVID positive resident, they will have to send the resident to a COVID hub unless they have a COVID unit in a separate building?
Under 690, if that is to pass. It's not in effect right now. They're going to be sending that bill to the governor's desk. Underneath that bill, a SNF provider will need to have an entirely separate building that is COVID only. And so there's no dedicated unit in that separate building. That separate building cannot be mixed in terms of patient or case.
Okay. Are HFA unlicensed assisted living and independent living communities included in the immunity bill? You mentioned listing AFCs and CCRCs.
In the immunity bill, there is some protections for workers in those facility groups. We've asked that they be specifically mentioned, and the legislature thought that they were covered under the language as is. They are not specifically specified under how they define a health facility. But the legislature doesn't really feel like they need to take up the mantle of specifically adding that language. We will see where it goes, and as I said, right now that bill is likely to be vetoed.
This is Deanna Dalton. I think that they're using the definition of healthcare facility as defined in the Public Health Code, which would include licensed HFAs and AFCs.
Yeah, I was more talking about the unlicensed providers. Sorry if I'm not clear about that.
Right.
All right, thank you for that. It looks like that is the last question that I had for this section, so we can go ahead and move forward. Oh, actually, one question just popped up. Can Leading Age please advocate that that would not be best in the interest of the resident to have to leave their home for an asymptomatic positive and have to go to a hub?
Yeah, there's been a lot of testimony actually saying that, and many legislators have actually, or legislators have brought that forth as an issue in the bill. This is largely right now a political move on behalf of the legislative Republicans to make her veto a bill that would essentially segregate out COVID positive individuals.
All right, thank you. And now I believe we can move on.
Okay, thank you, Dalton. And now on to the situation update. I probably would have stopped revising and updating these numbers each week a long time ago if indeed the caseload was improving. However, we know that that's not true, so we will continue to monitor this closely as we move forward. So this week we'll start with the World Health Organization summary of total cases by geographic area. And this graph is as of 7/20. You can see that North and South America mostly US and Brazil have the predominant share of the caseload. Looking at these new cases in the past 24 hours, as of 7:20, the WHO shows that there is surging in the Western Hemisphere, again, mostly in the US and Brazil, but there's also a new surge in Southeast Asia. In this map, also from the WHO, you can see that it is indeed US, Brazil, and that the Southeast Asia piece is really kind of predominantly happening in India. So cases are continuing to grow rapidly in those primary areas. So these data were collected by Johns Hopkins, and you can see that the US cases and the hospitalizations dipped to a low around June 1st and have turned significantly upward since then. Deaths were improving for a long time since they will lag behind caseload changes, and along with the fact that a large proportion of the new cases were younger persons. But note that they are beginning to climb when you're looking at national data. This slide shows our My Safe Start map, which has markedly deteriorated since just last week. Only the Traverse City area is now at medium risk, and there are 5 areas of medium-high risk and 2 regions at high risk. So cases per million population in Michigan is again climbing, as you can see, and that's an MDHHS graph on the right. This next slide is our standard 7-day rolling average of new cases for the past 60 days. You can note the continual incline. And the next slide, excuse me, is our 7-day rolling average of Michigan deaths, and that could be leveling off, but we would watch it very closely because there is a lag period between caseload and deaths. So this week, I've included a few Ziegler slides. They put out some data. They have a CFO report that speaks to caseload in senior care organizations and the current occupancy rates. Now, this is data that came from about 240 providers. So this isn't necessarily statistically sound data, but it does note some trends. And these 240 providers were mostly not-for-profits. Only 14% had not had any COVID cases. But currently, when you just look at the current data, less than half have current cases, so that's a better number. The southern region currently seems to have more facilities right now with active COVID cases, and that makes sense because we know that's one of the surge areas. Occupancy issues have been most critical for skilled nursing. You'll note that occupancy has gone down to 77% average among this group, and independent living was able to maintain an occupancy rate of 93%. This next slide from Ziegler also seemed kind of interesting. In 2020, the proportion of SNFs considering adding nursing beds was down to 3.9%. But fewer are also considering a reduction in beds than last year. So it looks like everyone's just kind of hanging on to where they are. And this last Ziegler slide shows the increase in monthly expenses related to COVID. And this is across all of the provider types that they measured. So about 65% have noted less than a 5% increase. But you will see that there are some providers who had as large as a 20% increase in cost. So with that, we're going to move on to member polling. We're going to kind of review and look at our comments and our trends that we decided on Friday. I am including detailed data about the numbers in polling, but we're not going to go through that slide by slide. I only included that in the slide deck so that you could review it if you chose to. So our first topic was visitation. These are the findings. I did also include the number of people who responded because that's important, I think. We chose this issue, visitation, because it seemed to be one of the areas of really high member concern and confusion over the last several months. So we chose that to review it first. So the next slide has the detail about a lot of the comments and a lot of the findings. So most members were looking for an update to the visitation requirements that would provide more quality of life, and we kind of expected that. But there are also some concerns about resident safety, especially in view of recent caseload increases. Most thought that unlicensed settings needed to be included in the visitation requirements and believe that they can handle visitations safely. Some stated that blanket requirements do not work given the range and variation of capabilities and performance across providers, and that's one of our key themes throughout all of our discussions with the state. So we will continue to focus on that. Hair care, still an issue, and we have talked to the state about that quite a bit as well, and we will continue to go down that road. And of course, there are some that believe that the governor should not be prescribing to unlicensed settings at all, and we anticipated that. So the next section was about testing and reporting, and there was some general concurrence that use of the MySafeStart map in determining testing requirements was inappropriate. In terms of the detail, on the next slide, we found that most members have access to PPE and testing kits, but there were some that do not. There were a lot of concerns about support and resources to assisted living providers, considering the frailty of their population, and the lack of any significant clinical care in those settings. Some were concerned that there was no publicly reported outcome or testing data for assisted living. And there were also concerns about how the antigen point of care test can possibly help. And we're going to talk about that a little bit later. Our next topic was about staffing, and several members during this discussion identified that this was their biggest challenge. Moving on to the detail, staffing challenges were obviously in existence for more than half the members before the pandemic. I think it was like 64%. But they did increase considerably since the beginning of the pandemic. And some of the issues there were competing with unemployment and also competing with other settings, such as nursing homes who were able to give supplemental payments. And that's just made it all harder to get staff. Waivers of certain flexibilities for staffing were recently discontinued by the state, and we have been very, very loud about that. We will continue to voice concerns about that because those flexibilities were very helpful to a lot of members in assisting in resident care. Many facilities commented that they did not feel comfortable caring for COVID positive persons because they don't have enough staffing, and that the MDHHS plan for emergency staffing will not really, in all practicality, help much. This next session was intended to focus on facility capabilities to serve COVID positive residents clinically. The ability to create dedicated units and kind of summarize member thoughts on regional hubs. So members commented generally, at least most facilities across the board, had a certain level of discomfort around their capacities to serve COVID positive residents. And just less than half of them currently had dedicated units. One of the interesting things to note was that with the lag time in getting test reports back, transferring residents to a regional hub doesn't seem to make much sense, and along with the fact that many families would object. So members believe that without a liability waiver, and this is a big issue, as Dalton has discussed earlier, that there's really no incentive to become a regional hub or even care for COVID positive patients. Even hospitals have difficulty in controlling transmission, and so there seems to be unrealistic expectations here of nursing homes, and of course assisted living as well. So our last section was about funding. There were really not a whole lot of surprises here. Moving on to the detailed comments. So with a focus on loss of census and increased costs, members were impacted by the inability to show apartments because of the visitation restriction. There were a lot of decreased admissions because families didn't want to place persons when they cannot visit. That apparently was a primary factor in occupancy issues. And there are a lot of issues confronting facility resources. And most members will be in need of further grants in order to make it through this. And that will be a Michigan advocacy piece, but more likely a federal piece as well. And I know that Leading Ages has some advocacy going on about that right now. So this is the summary of kind of what we heard last Friday. So I want to take a moment and just ask, is there anything of significant importance, a broad general idea that we need to add to this list of things that we just discussed? Any high-level issue that should be included in our list of topics to inform our stakeholders, policymakers, and most importantly, that task force? So we're going to pause for a moment and I'll hand it over to Blake.
All right, thank you, Deanna. Again, Leading Age Michigan, we would just like to thank our business partners and just give you a quick reminder to take a look at these logos on the screen. And obviously they support both of us, us obviously, and all of your organizations. So if you are considering purchasing goods or services, just please keep these organizations in mind, and thank you. All right, now I will go to the questions really quick. All right, I am being told the CDC recommendations changed, and now the recommendation is to have all staff members wear eye protection also with their masks. Is this factual?
Yes, that's true. We're going to talk about that a little bit later.
Okay, that is actually the only question I had. So I actually, nope, just got one more. We are experiencing a 2-week lag in receiving test results. How does weekly testing of staff and residents still make sense?
We understand that, and we've always said to the state that unless they get the turnaround times fixed, it's very, very hard to manage weekly testing or even make sense out of it. Their response is that they keep working on the turnaround times, but that even if there is a lag in the test reporting, they expect weekly testing to move on. So we continue to have those discussions with the state. There's so much confusion, things that don't always make sense throughout all of the guidance that we've been reviewing lately. And it has really been a challenge for members. We're aware of that. So we will continue to try and make sense of it as we move forward. It'll be interesting to see how the testing comes out overall. I would really want to see the results in that, because, you know, I think that even though transmission goes up, obviously, nursing home residents are going to be at risk. But if everyone has their arms around good infection control, what will the response be in those nursing homes? And we'll have to look at that and use that information to kind of form some of our discussions with the state moving forward. So I don't have a better answer than that, and I apologize, but we keep working on it.
All right. I didn't have any other questions come in, so I'm assuming we are good to go. So I will move it forward.
Okay, so we'll move forward to resources, but I do want to remind everyone that we are looking to create some hard advocacy around the issues we just discussed. And if you do believe that there's something missing from that list, please let us know, and you can email our Safe and Calm address, which we will remind everybody what it is at the end of the webinar. So moving on to resources and updates. As usual, we have an assortment of these updates from all sorts of different entities, mostly focused on the large number of CDC updates that they have issued in the past week or so. So this first one, last week, the CDC issued an update on social distancing. And while this doesn't have anything probably in it that we wouldn't already know, it felt like a really good guidance for some basic content to include in your staff trainings. So I have included it here for your review and information, and of course the link is at the bottom of the slide. So one of the bigger things is that last Friday, the CDC updated its testing guidance. And discussion with the department, MDHHS, yesterday confirmed that they plan to update their guidance to align with the CDC. So basically, there's an ultimate plan to perhaps eliminate test-based strategies as part of the requirements to discontinue transmission-based precautions. I mean, obviously testing in everybody's view is really important, but not necessarily to discontinue transmission-based precautions. Part of the problem was one that some of our members had experienced, and that was that test-based strategies can unnecessarily prolong isolation of residents and employees because they continue to shed the virus, which means that they will test positive, and yet they're not contagious. So the CDC, after looking at all of the data, recommends that symptom or time-based strategies be employed, except for persons who are severely immunocompromised or who have had serious illness for more than 20 days. Those persons, they believe, will carry a high viral load and be contagious for quite a while. So that's the basis for a lot of the updates that occurred last Friday. So this next slide addresses the associated guidance to testing and updates the return to work criteria for healthcare workers. And there are several CMS web pages that have been updated about the return to work criteria. So there's going to be several slides about that. But they changed, not only did they make a move to more symptom-based testing, they also changed the symptom-based criteria and reduced the amount of time that a worker must be free from fever, without use of medications, of course, from 72 hours to 24 hours. But they still have to be isolated for 10 days since the onset of symptoms or since they had tested positive. The CDC also changed some of the language in the criteria that stated that they had to have an improvement in respiratory symptoms, and now they're stating that they have to have an improvement in any of their symptoms. And that's mostly just because of the variation in types of symptoms that people have displayed when they have COVID. So our next slide really summarizes what was in the CDC's decision memo. In other words, the rationale and support for making these changes. Apparently, they have found that a person starts to lose infectiousness or the ability to infect others, that's a better word, a better phrase, after the onset of symptoms. And people with mild to moderate COVID pretty much will not test positive at 10 days after symptom onset. In very severe cases, those cases that were sick for at least 20 days, even though they were really sick for 20 days, 88% of them were positive at 10 days, but generally cleared by that 20th day. So positive cases in hospitals and in households, they found that no one became infected if the COVID positive person was in contact with them 6 or more days after onset. So when there have been close contacts in hospitals and households, if the contact occurred 6 days into the onset, no one became infected. So that tells you that there's a shortened time of infection for most of the cases. Some persons, though, will have shedding and therefore test positive for up to 12 weeks, but there have been no secondary infections found in this group. In other words, there have been no reinfections that they've seen either, but they don't believe that there's enough data to really judge that. And so these people are not getting a second bout of illness. If they're still ill and still testing positive, it's all based on the first set of illness as far as they know so far. So if positive patients continue to test positive during the 90-day period, retesting does not provide much useful information at all. And this is one of the factors that will probably impact the Michigan testing guidance, according to the department yesterday. There's no reason to be testing positives during a 90-day period. And I think right now, the state says for 6 to 8 weeks, you don't need to test positive people again. So this moves that time frame out to 90 days. The state said that they will be updating their guidance, but they, of course, have not done that yet. So if a positive person does become symptomatic in those 90 days, they should be reevaluated for infection, and consult with an infection control expert is recommended. However, there have been no identified cases of reinfection to date, and it's thought that the risk for reinfection continues to be quite low, at least for the first 90 days. But there's really not enough data over time to know how long that immunity to reinfection might exist. But it hasn't been studied well enough. So because of all of that, the CDC recommends that for most symptomatic persons, isolation and precautions can be discontinued 10 days after symptom onset, as long as the fever's been gone for 24 hours without the use of meds, and therefore time or symptom-based strategies are recommended for most persons. Persons with symptomatic COVID, but who remain symptomatic after recovery, need not be tested for the next 3 months. And during that time, quarantine is not recommended if they should come into close contact with someone with COVID, as long as they continue to meet the criteria to discontinue transmission-based precautions and they have no symptoms. So in other words, if a positive person has been exposed to another acutely positive person, you don't need to quarantine them for those 90 days. But persons, they worry about persons who have had severe illness or are immunosuppressed. They should be looked at on a case-by-case basis, and infection control experts consulted about that. Persons who are asymptomatic simply discontinue precautions at 10 days after the first positive test. Any one of those persons who develop symptoms within the 3 months should be evaluated by an expert, especially if the symptoms redevelop within 14 days of contact with someone with the virus. But all in all, I think it clarifies a lot for us about how this infection is transmitted, and the fact that the most serious time for being infectious is really within the first few days after symptom onset. And of course, testing after the test as well. So the CDC also updated its strategies to mitigate healthcare personnel staffing shortages, but it was only updated because of the new information about testing that we just went over. So otherwise, there's not anything new here, but I included a summary of the content for those who might want to review the guidance. But this slide only covers half the guidance. There are a couple pieces on the next slide. So it's really mostly about the immunosuppression piece that that this guidance reflects. So if you go to the next page, this is the second part of the guidance on mitigating healthcare personnel. And you can see that there's new language about the immunosuppressed. And it's really important to keep anyone with suspected or confirmed COVID away from such vulnerable persons. Those are the persons who are likely to get very, very sick. And although local or state public health departments should be consulted first, there's always been an option to let COVID positive persons work in situations if they are asymptomatic as part of the need to pull extra staff in. But to date, we are not aware that MDHHS would approve of that, but the CDC has always listed it as a possibility. So in summary, obviously the return to work criteria was also updated to address these new testing guidelines. We talked about the changes to the symptom or time-based strategies. The test-based strategy is still an option, although there are rumors that the CDC is considering eliminating it entirely. The testing strategy still states that 2 consecutive negative tests conducted at least 24 hours apart would meet the criteria for discontinuing precautions. And of course, the CDC is always going to defer to what's going on locally, local and state guidance based on the conditions there. One thing that's really interesting is that they still recommend 14 days of quarantine after exposure to the virus. So it's possible that someone could get out of isolation if they tested positive earlier than someone who'd only been exposed. That's a possibility. So this is the guidance that we received an awful lot of questions about. So this was updated as of July 15th. It is the infection prevention and control recommendations for staff. And they added language that eyewear that's designed like glasses, more or less, will not protect eyes from all splashes and sprays. That's the first piece. Universal control and need for face masks continue, but they've added some new recommendations based on the level of community transmission. So for areas with moderate or substantial community transmission, which we have to say is not quantified anywhere in guidance about what that means, staff should follow both standard and transmission-based precautions and wear eye protection for all resident care in addition to masks. Their rationale for this is that in areas with a lot of cases going on in the community, there's more likely to be persons who have the disease but are asymptomatic. So we did receive several questions about the use of shields in the past week, and mostly about whether or not facilities have to do this. So this is a very, very gray area, and one that we have struggled with since the beginning of the pandemic. There are very few areas in CMS policy memos that say you must follow a specific CDC guideline. And they do, though, however, refer to those guidelines all the time, but they say consider, or they say we refer you to. There are very few things that say you must follow this CDC guideline. And part of the problem with that is that the CDC guidance is not always consistent with itself. And on top of that, the state can come out and say something different as well, which they have done with N95 respirators versus face masks months ago. So unless CMS mandates a specific requirement, each facility has to kind of weigh that against the current environment and the potential risk for not following the guidance. one of the issues is that if you're in a region that might be 15 counties large, and you have a level of moderate community transmission, but maybe not in your county and maybe not in your area. You know, our regions do not necessarily equate with whatever the CDC is recommending. So again, there have been some, I know, citations for nursing homes for not following the CDC guidance for some things. So when you choose not to follow the CDC guidance, you probably are taking some risk. And if you choose not to do that, you need to have a rationale for it. But you need to look at the entire conditions in your community. And we do encourage that you talk to your local health department and the state public health department if necessary about some of these CDC precautions. However, for this one, for at least some of our members, the local health department didn't know the answer to whether or not face shields were really going to be required across the state. So again, a gray area. And at this point, there's probably some risk in not following all the CDC guidance, but every facility kind of has to look at that themselves and the community that they're in. So one of the things that was on the last slide, if you go back just for a moment, Blake, I'm sorry. One of the things that they included in these updated infection prevention and control recommendations was to ensure that you have a documented process to respond to exposures. And now you can go ahead, Blake. So with that need to have a plan to respond to residents or staff exposures to the disease, the CDC has issued a template for a risk assessment to determine the level of risk for a worker who's been exposed. And the link for that template is right here as well. And this is just the first page of that risk assessment. There is no requirement that you use this. It is just an option. The next slide is the process map that explains the recommended process for dealing with these staff exposures. And the link for that is here as well. Lastly, they have developed a self-monitoring tool for staff to self-monitor if they have been exposed. And again, these are just resources for you. So there are a few other updates. There was an updated guidance for consumers who are at risk, including persons with disabilities. There are updates to the CDC trainings on how to use PPE. There's an update on considerations for transfers to relief facilities. And a relief facility would be like one of our hubs, or if we were using any other kind of alternate care site, but we don't in Michigan. We also included here a notice that the FDA has approved pooled testing, which would really work well for serial testing, we think, not necessarily during a major outbreak. And when they pool testing, what that means is they simply add many specimens together and test them all at once. And they only run each individual test if the pool is found to be positive. And they anticipate that this would be helpful only when there's a realistic expectation that about less than 10% of the individuals will be expected to be positive. Medicare cost reporting. CMS has extended the due dates for cost reports. The updated dates here are listed for it's September 31. I'm sorry, I have this backwards in my head. It's September 30 for cost reports ending 2/29, August 31 for 1/31, and 12/31/2019. So the other thing that CMS has issued notice about is that they're resuming audits of healthcare providers' Medicare claims in the next 2 weeks. So the next slide and subject is about reimbursement from MDHS for testing. And this has been a really difficult and confusing process all along. We've already gone through several iterations with the state of their guidance, but we assumed incorrectly that serial testing in nursing homes would not be included in nursing home consolidated billing, and we were wrong about that. So we reached out to the state last week to let them know that if weekly resident testing were required, that this population, the short-term stay Medicare population, the cost for them would be prohibitive. And we asked them whether or not they would expect to cover these costs as well, because the state has all along said that they would cover anything, any costs for testing that would not be covered by insurance. The expectation was that nursing homes would not have to do that. We also suggested that the guidance would need to be updated because labs would not be billing for Medicare A fee-for-service covered stays, and that's not what their current guidance says. So we're not also sure that all new or returning resident testing should be covered by all insurance, as their guidance memo says. Unless there's a symptom, we believe that commercial insurance are likely not to cover. But we are kind of waiting to see how that plays out. So we have offered an awful lot of input to the state in the past week, and we're hoping that they will update the guidance accordingly. It's our hope and expectation that they will cover all the testing, including Medicare A, covered residents, but we've not heard anything back to that from them officially. Point of care testing. This is another area that sounds just great when we first heard about it, but we've spent a lot of time looking at this, and I at least am quite confused about the point of this. I guess there is some benefit, and we'll talk about that benefit in a bit, but part of the issue is that the types of point of care tests that the feds plan on sending are all antigen tests. In other words, they're testing to see if a person has had the disease, and they're not testing for the presence of the virus currently. So it would seem that if the test was positive, the person would need to be retested using a standard virus test. The other issue is that the test has a high accuracy rate for positives. So if you get a positive finding, the likelihood is that you are positive. But what that means is that you've had the disease at some point. But it doesn't have a good accuracy rate to determine negatives. And there's a significant amount of false negatives, which would suggest the need to retest there. So it just seems that there's such a level of retesting needed, we wonder how effective this will be. And facilities, as we've discussed before, have to have a CLIA waiver to conduct the test. And some training is being planned, so we're hoping that these issues are addressed in the training whenever that comes out. The criteria for determining the facilities who will receive the test first is listed here on the bottom of the slide. So I guess that if we're going to retest negatives on a weekly basis, and you're going to retest using that point of care rapid testing, rapid test, then maybe if that's the way you retest negatives, then maybe there's some benefit to doing the weekly testing. It's only a nasal swab, it's not nasal pharyngeal. And maybe you'll get enough good information to monitor the negatives over time. But it does appear that if you get a positive, you're going to have to do a regular viral test anyway to see if somebody actually has a current bout of the infection. So it's just kind of confusing, and we're going to be monitoring this as we go forward. So this is the updated guidance about the direct care worker wage increase, and that was just updated yesterday, and Dalton talked about it. One of the concerns that we have is that they updated the FAQ, the frequently asked questions, but there's still no published guidance. So if you read the FAQ, it's almost like you all of a sudden jump into the middle of a conversation and you're not sure where it starts and ends. So there's a lot of confusion about this still. Without benefit of a final written guidance, this is our understanding, that the supplemental payment for direct care staff is for nursing homes who are either Medicare or Medicaid certified. This is based on legislation. It is not about providing money only to Medicaid resident care or for persons serving Medicaid residents. It doesn't have anything directly to do with Medicaid. It's only that the direct care staff have to work in nursing homes who are either Medicare or Medicaid certified. To be honest with you, we're not quite sure why that is. The updates are bolded here from the FAQ that was issued last week. So contract workers are not eligible. That's an update. They never were eligible, but they made it more clear. And one of the things that I thought was interesting is that they will pay overtime. In other words, if someone is working overtime, they will receive a total of $3 per hour instead of just $2 an hour. And it has to be persons who work over 40 hours a week or using the over 8 hours or 80 hours in a pay period kind of system. So those are the changes and the updates to the direct care worker wage increase. But I've gotten a lot of questions about, well, what if you don't have any Medicaid beneficiaries? This is not related to Medicaid. This is if you're Medicaid certified. That's the only relationship to Medicaid. So last, but certainly not least, just to let you know that CMS has started an initiative to study the issues in nursing homes who've had a sharp spikes in caseload. They're going to focus a review on 18 nursing homes across several states to look at some of the facilities processes. But these are not surveys, and they are not done by survey teams. They will refer problems to the survey agency if they feel it's needed. And this is a very small pilot, but they anticipate that they might expand this if it proves effective. So the questionnaire that they're using is listed on the slide there. And pretty much they're going to be looking at process issues around infection control and managing COVID cases. So that pretty much ends our content for today. We do have some final reminders. There is a QIO training with the CDC tomorrow. It's titled, "Is Your Nursing Home Ready to Handle the Demands of the COVID Pandemic? Assessing Readiness Advice from the CDC." It does look to be a fairly important piece. The link is there. I believe it starts at noon. There is a new National Governors Association memo. Well, actually, it's not brand new. It was just updated on July 13th. It's fairly lengthy, but it talks about COVID strategies for long-term care. And we are currently reviewing it and plan to discuss it a bit on Friday. If you want to review it in advance, the link is right here. So that ends our discussion for today. We will open it up to questions, and I will turn it over to Blake.
All right, thank you, Deanna. I'll just get right into the questions here. We have a few. CDC says use standard and transmission-based precautions if required on the suspected diagnosis. If we have no suspected diagnosis, are face shields necessary?
Yes, if you're going to abide by the CDC recommendation, which should be based on whether or not you have a lot of community transmission around you, you are required to use the face shield for all resident care. That is the intention of that guidance. It isn't just whether or not you have COVID in your facility. It has to do with the fact that they want to increase the level of protection because if there's a lot of community transmission in the local area around you, the chances of asymptomatic people moving in and out of your facility in terms of staff, if not visitors, we know that there's no visitors, is rather high. So that's why they have upped that requirement.
All right. Were gowns removed from the PPE CDC guidance, or did it just happen that you did not mention it?
I'm not sure. I generally put all of the critical elements from the CDC guidance. I will have to go back and look at that. I can't imagine that gowns were removed, but let me look at that. It might be an error on my part.
All right. Is there any guidance on the due date for 3/31/2020 and later cost reports for Medicare?
Can you repeat that, please, Blake?
Is there any guidance on the due date for March 31, 2020 and later cost reports for Medicare?
No, not that I'm aware of right now. I only know about the dates that were issued from CMS, and those are the ones that I had on the slide.
Okay. Is the $2 an hour increase for direct care staff who may not be CNA, may be just personal care assistants?
No, you have to be in a licensure or certified category. So you have to be a CNA, an RN, an LPN, or I believe a respiratory therapist.
Okay. How are facilities allowing any outside visiting, or is it still limited to hospice and ADL decline because of lack of visits? Any idea how long the weekly testing will continue?
So visitation is still limited to those two groups, ADL assistants and people at end of life, and there's some, discussion about who those groups are in the MDHHS recent guidance about that. And so the answer is no. We anticipate that visitation issues will follow. Visitation will open up when community transmission seems safe. And at this point, community transmission seems rather high and continuing to grow. So we don't anticipate that the governor's going to change this until she thinks that we have our arms around it. And I know from a lot of her comments recently that she does not believe that we have our arms around it.
All right. And then we do have a couple more questions, but I just wanted to remind everyone I did switch the slide over here. So if you do have any questions, feel free to shoot them over to the safe and calm at leadingagemi.org, or you can go directly to Deanna Dalton or Laura Funch. Do you want to mention that there is a POC testing that is molecular and is not being provided, just so folks know it is out there?
Sure. In fact, I know who that came from. There is a point of care test that does directly measure the virus. However, it's very expensive, but it is not the test that HHS is sending to nursing homes. So that is part of the dilemma as well. It seems like it would be a lot more useful, but that's not the test that nursing homes are getting.
Okay. And then someone said, so I'm going to go back a few slides here. Someone said that the link on slide 46 and 47 does not take you to these documents or take you to the pages, it looks like. So it would be this link right here, Deanna, and this one. So I don't know.
Okay. Well,
just
if you're trying to do it from the PowerPoint, the links will never work from the PowerPoint. If you're saying that the links are wrong, we will recheck them.
All right. Has MDHHS released an FAQ or more guidance on 333.2253?
Okay. I believe that that's a public health code that gives MDHHS authority to provide guidance during a pandemic or a state emergency. So that is simply the public health code that supports the department's ability to do that. It is listed as part of the support for a lot of different guidances that have come out from the state, so I don't know which guidance you're referring to.
Okay. And other than that, I'm not seeing any other questions, but she said guidance, no, or guidance on the visitation.
Right, I was anticipating visitation. So as I said before, we have no new information about visitation. I believe that basically they're looking at testing to kind of give them a sense of how things are going in nursing homes. They're going to be looking at that data over time along with community transmission, but we don't see any inclination on the state's part at this moment, at least, to open up visitation. But we do want to talk about that very in detail in the task force. And that task force that Dave Herbal is representing our members on is designed specifically to look at what have we learned, what can we do to make a second wave smoother for residents and providers. So we want to make sure that we're informing that group, but at this point, we don't know how long the visitation requirements are going to last, and we're still living in a world with escalating transmission. So it's likely to be at least a couple more weeks. Hopefully, with the mask rule, my understanding is that the public use of masks is supposed to be very effective. Hopefully, we will soon see some declines again in community transmission.
All right, thank you, Deanna. So someone said that they were able to download the MDHHS handouts, but not the presentations. I know that some people have had some issues grabbing the presentation, so I'm just going to show you really quick. I'm going to drag this over. If you go to leadingagemi.org, this banner right here is going to be the first thing that pops up. You can go ahead and click on that. This is our COVID-19 tools and resource page. So you can go ahead and scroll down, and then once you reach, I guess it's right around the middle of the page, these previous webinars. These are all the previous webinars for the links of the PowerPoints. So let's just say the 15th, you can go, oh, apparently that one is not working. So I'll have to fix that. But here's the one right before that, July 8th. So you can go ahead and click on those. And you should be able to download them right from there. And if you're also interested in just watching the recordings, you can do that as well. So we have all that there. I usually try to get the PowerPoint and the recording and everything up the same day that it happened. So we should have the PowerPoint and the link to the recording by the end of the day. Other than that, I think that takes care of everything. So I believe that we had around near 80 participants and members that took time out of their busy schedules to join us today for today's webinar. We appreciate everything that you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Again, just thank you to Dalton and Deanna for everything, and thank you everyone for joining us. I think that takes care of everything for me. Dalton or Deanna, do you have anything else that you would like to say?
I just want to wish everyone a good day, and remember that this is a very confusing time, and we are working hard to try and work through it with you, and hopefully we will get to the end of this soon. Thank you for everything.
Thank you.
Thank you. And I just had a last question. Someone asked when the next call is. Our next call is scheduled for this Friday at 11 a.m. Eastern Standard Time. Thank you and have a great day.